Today I'll be rounding up with treatment of osteoporosis before the questions, and there's a little bit in the bracket including FRAX. Now, the problem with guidelines is that the moment they get published, they are out of date already. So what I want to do is maybe address quite an important area, which is the treatment, and then perhaps show some other data that might change our paradigm about the way we think about osteoporosis. But at this point in time, what we have put in the guidelines is 2009, this is how we treat. Okay, but I'm just going to show you a snapshot of what might eventually change. Now, osteoporosis drugs have been around now since mid-90s. So that means we've had them for about 15 years. A lot of times people have mentioned that the problem is that osteoporosis is an undertreated disease. I think in Singapore, in some instances, it's an overtreated disease. And so how do we think about, how to use these drugs? So the scope of my talk today is I'm going to discuss the available drugs, deciding who to treat, and choosing a drug. Now, outside, we've got a lot of companies. The turf war in osteoporosis drugs can be quite, I wouldn't say dirty, but okay, so, when we put objective evidence, all right, so I'm going to put out numbers because these are the objective things that we see, all right? Now, we make a lot of inferences, and if we look at pure evidence, it's slightly different from what we usually do. Okay, so therapies for osteoporosis, on the left are the anti-resorptive agents. There is only one true anabolic agent, which is parathyroid hormone. There are some agents with heterogeneous effects. Strontium is one of those where, although it increases bone formation markers, not everybody agrees it increases bone. There are new agents that are in the piping that they will come up. But by far, the main armamentarium that we have are the anti-resorptive agents. Now, I'm not going to talk today about whether we should combine agents, so I'm just going to talk about currently what we use singly. So if we want to review the evidence, let's do so. If you look at how people have put people into trials, most people actually include people with vertebral fractures. So everybody has done trials with vertebral fractures. There's only one drug which was recently published that actually looked at patients with initial hip fractures. We have patients who fracture, but the majority of our patients actually haven't. So if we look at the data about who has done studies on people without prevalent fractures, you find that actually not all the drugs have done this. Okay, but what we do say is that all of these drugs are useful for osteoporosis. Okay, so not every drug actually has looked at as a primary objective patients without any fractures, but with osteoporosis. And in fact, much less have looked at osteopenia. In fact, nobody has. So these dots here that you see, these are what's called post-hoc analysis. In other words, they milk the data to get some positivity. Okay, it wasn't the plan. So if you look at vertebral fracture efficacy in post-menopausal women, I put a line down here, which is 0.5, which is about 50% reduction. Now, I'll tell you that no drug has been directly compared against each other for anti-fracture efficacy. So all the competitors outside who are saying my drug is better than yours because of how many percent, actually they're all in the same ballpark. I'm a fair man. It's between 30 to 50%, and if you do one study in one center, it's 30%, on another center it's 50%, on another center, and then when you meta-analyze all of them, you get another percentage, but generally in the ballpark, they are mostly about the same. Perhaps some outliers might be zoledronate, perhaps PTH, but generally most people fall within 30 to 50%. All are about the same. What about looking at those who have reduced non-vertebral and hip fractures? For non-vertebral fractures, again, most of them have actually looked at those with prevalent vertebral fractures. For those without fractures and checking its effect on non-vertebral fractures, in fact, very few. Again, zoledronate has looked at this in terms of those with an pre-existing hip fracture. The story is pretty much the same for hip fractures. If you want to prevent hip fractures, most of them have already broken their bone. But if you look for studies on those who haven't broken their bone in reducing hip fractures, actually very few people have done studies to look at it. Okay, so what's the data on the impure evidence that we extrapolate and say we should use it on everybody? Okay, so what we see here is that there's non-vertebral efficacy for some of these drugs, but you can see that the effects are much less than for vertebral fractures. Okay, so there's some of these drugs that have been shown to work on non-vertebral fractures. Some of these that border one, the data is milked so that you could get some positivity, but there is some data. So I'll kind of summarize later on this data. So again, we get some idea. Now, I'm not going to talk about anything in the guidelines because the guidelines puts it out as a qualitative description. It tells you this drug does this drug does this, okay? But I'm trying to put it out comparing the drugs together, which we don't do in the guidelines. And one of the problems we have is that we don't tell people what to use in the guidelines. So I'm just trying to give you an idea that in a sense, most of these drugs are pretty much the same. Nobody has got very good pure data. This is the data on hip fracture efficacy. And again, you see that not all the drugs actually have benefit in hip fracture. Okay, so I'm going to go to another part, which is deciding who to treat. Okay, so actually this table, I asked Tang Chin, how come this table wasn't inside the guidelines? Okay, it was in the 2002 guidelines. And essentially, it turned out that most of the time, we based treatment recommendations on what the bone density is. So this kind of picture, except for the action, this is what Seok B showed just now. And if you have severe osteoporosis with a fracture, you should basically treat. So that's the top group. You should basically treat them. The recommendation, if you have osteoporosis, actually you should consider treatment. Okay. Now, osteopenia, this word which Tang Chin mentioned, which is prevention. So prevention means that you do some of the lifestyle measures. Now, some of the drugs earlier on have made recommendations that you kind of use the osteoporosis drugs in osteopenia. I think that's kind of tapered off. So now we consider those with osteopenia with multiple risk factors because it has been recognized that those people who have higher than osteoporotic bone densities might still fracture. Now, if you look at your population of people to be treated, actually there are three basic patient groups. Firstly is those who've got fractures. Secondly, those who are osteoporotic but before fractures occur. And thirdly, osteopenic patients. There's nobody else. This is all the women there are. And I'm talking about women. Now, there is some basis for it. And this is actually the way it turned out that when you look at the trials, the efficacy of drugs seem to correspond to the BMD T-scores. And that's because historically, people get enrolled into trials based on BMD if they haven't had a fracture, okay? If we look for pure data again, okay, for those with osteopenia, this one is kind of, as I showed, it's kind of milked data that they showed some benefit. Okay, so regardless of your density, they will actually reduce fractures. But the question is whether the fracture is frequent enough to warrant treatment. HRT never intended to show, so they never measured bone density, but in fact it's been shown to reduce vertebral hip fractures, non-vertebral fractures. Now for those without fracture, actually very few drugs have actually been used in that scenario. So we have alendronate, risedronate, raloxifene, and strontium. Out of these, only one of them seems to have at least data showing that they reduce hip fractures, risedronate, non-vertebral fractures. For those with severe osteoporosis, almost everybody has data, okay? And this is, so this is alendronate, risedronate, zoledronate, and we have strontium, raloxifene, PTH, HRT, ibandronate, tibolone, etidronate, calcitonin, pamidronate. So everybody has. But I put these slightly smaller because these are older data, less robust. And then we've got this subgroup analysis where people have said, oh, let's look at other groups and other groups and other groups. So we have subgroup analysis for people who are older, with or without fracture, with very low densities, and then some of these have been shown to be beneficial. So this is really the state. And basically in 2009, this is what you go home with the idea, and more or less this is how you would start treating patients based on this. Now, of course, we've also seen data that it's clear that if you looked at individuals who have fractures, so these are hip fracture cases going up in here, this is actually the population. This is minus 2.5 standard deviation. So if you look at these, okay, 17% of this population had osteoporosis, and this is actually the rest of the 83% without osteoporosis. But if you look at it, the number of people, actually about more than half of women who had fractures actually were not in the osteoporotic range. Okay? But just in case we decide to want to throw away bone density, it's actually quite important because if you look at the proportion of those below minus 2.5 with fractures is actually 8%, and the proportion with fractures above it is 2%. So there are far fewer fractures, although the total number is higher, but in relation to the population that you need to treat, it's much lower. It also tells us that maybe BMD isn't the whole deal. Now, this is basically what we do, and I put out, because Seok B talked about it as well, that age was an independent risk factor, and the T-score or the BMD. So if we base on a fixed BMD threshold, regardless of your age, everybody gets treated. So on the red is danger, okay? This is the dangerous people. On the green is not dangerous, okay? But we know in all biological systems, this isn't so. You know, we're all part of a continuum. Is this valid? There's some epidemiological data available, and this comes from Hong Kong. And I use Hong Kong data because the osteoporosis rates seem to be parallel to Singapore. So I think Hong Kong has done some very, very good research, and this is Annie Kung's data. What she did was to actually prospectively follow people for 10 years. So they have 10-year fracture data. And just based on age and BMD alone, this is the percentage. So this group was more than 20% risk of fracture in 10 years. This was 15% risk in orange, and in the yellow bars were those with 10% risk. Now, where we draw a risk that we need to treat, that actually depends on how much money we have. So for example, if it's worth, and how cheap the drugs are, and so if we have lots and lots of money to spend, then we can spend more money on more people, so we can say that, oh, it's worthwhile for us to treat those with slightly lower risk. If you didn't have money, then you say, oh, I want to reserve my money for those who are very high risk. So you put a cutoff. So we actually don't have an idea where our cutoffs are, but people have kind of recommended that we use 20% as a risk. So if we look at it then, that it turns out that we are recommending to treat here, but in actual fact, if we followed up the risk of breaking bones, it seems to be a little bit less. And so then the question then is that, okay, so what about this in terms of treatment? So because we have this kind of data out, this you've seen before from Seok B. This is the FRAX. Now, this is the website you can go, and some people are starting to use it. So I'm just going to show it to see what are the limitations, what it shows us. Okay, so this is quite interesting. The relevant databases, which for Asians, okay, so the rest of them are Caucasian database. They do Americans and UK and everybody else. But for Asians, there are 3 databases which are relevant: the China, the Japan, and the US Asian. And then the risk factors that you throw in are these. And if you look at these, well, I guess you could say that most of them seem to be mediated by bone density. You know, whether fracture or fractured hip, or whether you smoke, glucocorticoids, rheumatoid arthritis, all kind of mediated by bone density. And the other risk factors are weight and height. So you actually need to plug in, and depending on your population, you need to plug in which, if you click for calculation tool, it gives you these databases. Then you click onto the database and it comes up here as the database that you want.